Ladies and gentlemen, good morning, good afternoon, and good evening wherever you are in the world watching and following us live. My name is Flora Cobello. I'm a proud registered nurse. Olen ylpeä sairaanhoitaja Hykkönä Freirangol. Ipinagmamalaki ko po ako po ay isang rehistradong nurse. I am a lecturer at the Vascular University of Applied Sciences, International Degree Program in Nursing, Doctoral of Health Sciences, candidate at the University of Eastern Finland, and the chairperson of the Filipino Nurses Association in the Nordic region, and also board members council at the Healthcare Without Harm Europe. Welcome to the World Health Summit's one and only panel discussion for nurses, entitled Nursing in the Time of COVID-19. This afternoon, we will be joined by the experts in the field of nursing leadership and management, health workforce, and evidence-based nursing. I present to you the distinguished panel of members in today's panel discussion. We are joined by Ms. Elizabeth Iro, Chief Nursing Officer of the World Health Organization. We also have Mr. Jim Campbell, Director of the Health Workforce from the World Health Organization. We also have Ms. Annette Kennedy, the President of the International Council of Nurses, Professor Katri Vehviläinen Julkkunen, Doctorate of Health Sciences Chair at the University of Eastern Finland, and also a Nursing Director at the Kuopio University Hospital. And also we have Professor Dame Donna Keenair, the Chief Executive and General Secretary of the Royal College of Nursing. Welcome to the panel discussion. It would have been very nice to meet you all in person, but as they say, there's always a reason for everything. Hopefully next year will be a brighter year for all of us as we especially celebrate the International Year of the Nurse and Midwife until next year. So for the information of our viewers online, this panel discussion will last for 90 minutes. And each one of you following us right now will have the chance to ask some questions. Due to our limited time, we will only choose some of the relevant questions from the chat box. So stay tuned, everyone. So I speak on behalf of the millions of nurses who are working in the clinical field, who suffer in agony, who are anxious of what the future holds for this profession, and who are dismayed on how the society has treated us during these pandemic times. I myself thought that the leap of faith will go with us, that our worth and value in the social and healthcare system will be much highly appreciated with our presence in combating the gruesome effects of COVID-19 virus. I was working myself during the peak season of COVID-19 in Finland at the Helsinki University Hospital, and I see how my colleagues experienced burnout, and some got even infected with the coronavirus. It was very unfortunate. Over 1,000 of nurses have died uncompensated, undervalued, and underpaid. While we appreciate the clap and standing ovation, but this cannot bring anymore the lives of the lost colleagues. Thousands of nurses wanted to leave the profession and change career because they have a family and children waiting for them at home, to whom they couldn't even see for many weeks because they wanted to protect them from the risk of contacting the coronavirus. And we all know that for the past decade, the role of the nursing profession has long been proven vital in the global health and during pandemic crises such as Zika virus and Ebola virus. We are the frontline workers delivering essential care based on the available resources with the highest form of work morale and ethics to the oppressed, depressed, exploited, and deprived vulnerable groups of the society. During pandemic times, nurses are also involved in the planning, organizing, implementing, and evaluating the effectiveness of the healthcare services using existing evidence-based practice. But despite the evident role of nurses in the social and healthcare system, our visibility in the decision and policy-making process is still limited, are not given the maximum potential to utilize their skills and competencies. So in relation to that, to what I mentioned, Ms. Elizabeth Iro, can you please tell us about the critical points of the State of the World's Nursing Report in relation to the present pandemic situation of COVID-19? The floor is yours.
Thank you very much, Floro. It's a real honor to be a part of this 2020 World Health Summit. The COVID-19 pandemic in the International Year of the Nurse and the Midwife has not only put a dual spotlight on nurses and midwives, this has provided the platform for identifying opportunities and the challenges to advancing and strengthening the nursing and midwifery professions. The State of the World's Nursing Report is a landmark report. It reveals that there are much to celebrate about the nursing workforce. The report showed that we do not currently have enough nurses to achieve universal health coverage. The nursing workforce has grown over the last 5 years. There are now 28 million nurses worldwide, but there is still a shortage of 6 million nurses. Now, this shortage is predominantly about 89% in low and lower middle income countries. The relevance to COVID-19 is that not having enough nurses impairs a country's ability to respond to the pandemic. The inequality of the distribution of the nurses around the world means that those who struggle to provide essential services and achieve universal health coverage will probably see a decline in essential services as they try to respond to the COVID-19 pandemic. We must address the shortage and maldistribution to both respond to the pandemic and to truly leave no one behind. The report has also showed that the international migration of nurses is closely related to the shortage and the distribution of the nurses globally. We found a distinct difference in the reliance on nurse migration by country income classification. High-income countries had about 15% of their nursing workforce were born or trained in a country other than where they were working. In low and middle income countries, it has less than 1%. So not having enough nurses in their pandemic response may prompt countries to look to international migration. This can worsen the shortages in countries struggling to provide essential services. When it comes to aging, aging was another critical point in the report, which showed overall the nursing workforce is relatively young, but some regions and countries have a dwindling replacement pool for retiring nurses. For future pandemics and to ensure an appropriate number of nurses per population, countries will need to ensure that sufficiency of the number of nurses entering the profession and those retiring. Countries may need to increase domestic production of nurses and retain the current ones being employed. This may mean increasing enrollment in nursing by younger generations and groups not equally represented in the nursing workforce, for example, male nurses or minority groups. Yet to address the social status and the perception of nursing, I think is going to be really critical for us to do. COVID has also prompted countries to review their retirement age for nurses and entice retired nurses back into the active workforce. So in regards to education, the report showed that there are a variety of levels of education programs for nurses, from 1 to 2 year programs that offer certificates or diplomas, to 3 to 4 year programs that offer degrees, and varying quality of these programs. There are also major challenges with the capacity of education and training institutions in terms of the number and the competency of faculty, infrastructure and technology, and the availability of clinical placement sites. In this pandemic, COVID-19 precautions present a particular challenge to educating nurses, as most institutions are forced to rethink how they deliver course content safely and remotely. Curricula now also need to incorporate how future health professionals utilize technologies to provide telehealth and communicate through virtual as opposed to in-person means. For some countries, this may require reorientating education towards primary healthcare, emergency preparedness and response, interprofessional education, and ensuring digital health literacy of graduates. For others, the pandemic has highlighted the key roles of nurses in providing health services, and they may wish to expand the production of nurses at the degree level or at the advanced practice nursing level. We know the report found that advanced practice nurses, appropriately enabled and supported, can provide highly effective preventative and primary care and treatment of non-communicable diseases, as well as other services instrumental to achieving UHC. This level of nurses could be leveraged to provide advanced clinical services in routine care or in emergency response. The report found this role presented in slightly over half of the responding countries. So depending on the service delivery model, advanced practice nurses can deliver a wide range of advanced clinical services in COVID-19 response and preparation. The report revealed that regulations on working conditions, such as social protections, the working environment, minimum pay, the hours of shift, etc., were mostly in place. However, only 37% of reporting countries said they had measures in place to prevent attacks on health workers. We would like to see those protections more widely available. What we have seen during this pandemic is countries where the regulations on working conditions are not in place. This absence can contribute to stress, burnout, absenteeism that can cause a substantial decrease in the service delivery. COVID-19 has also fueled a stigmatization of health workers, and we have seen a dramatic increase in discrimination and attacks on nurses and other healthcare workers. The finding on leadership found that 70% of those reporting countries have senior nurses in government responsible for health policy decision-making. Approximately half of countries had a national leadership programs for development programs for nurses. Where there was a government chief nurse and the leadership development program, the country was more likely to have education standards, regulations on working conditions in place. So with strong nursing leadership, there is ability to lead a pandemic response, mobilize and appropriately manage the largest component of health workforce in response. The report provided the best data we have had with 191 countries responding, but countries' ability to report is not at the level necessary to understand the labour market in a way that is needed to make evidence-informed policy decisions. Key gaps were in areas of education, such as the number of applicants, the graduates, faculty ratios, tuition costs, government expenditure, and key labour market flow areas like unemployment, vacancy rates, salary and wages, migration, and in what types of facilities nurses are working. Countries now more than ever need to know how many nurses they have, how many are in the pipeline, what their training levels are at, in order to ensure they can provide the essential health services, as well as respond to emergencies. The report provides data and evidence and makes strong recommendations for investment in strengthening nursing leadership, nursing education, and nursing jobs. Thank you very much.
Thank you so much, Ms. Elizabeth Iro. The critical points you mentioned indeed need urgent action from the decision policymakers so that the report moves forward. And you mentioned about the Advanced Nurse Practitioner Program, which is under development in almost all parts of the world. And we really need legislations to support from our government leaders to pass laws that would help advance the nursing profession. Also, you mentioned about migration of nurses from low and middle income countries to high income countries, which makes the health system of the source countries very fragile. But the issue here there is we can't prevent migration. It is a human right, but we need sustainable integration programs to help these nurses adjust well in the country of development. So countries which might need nurses during pandemic times or war, example, because of strict restrictions, may not be able to help those countries because it prevents them from practicing the nursing. So this was mentioned in the State of the World's Nursing Report, where we need harmonization and systematic and easy qualification and credentialing process. And it's very unfortunate that a lot of our colleagues during pandemic times have also died from contacting the coronavirus. And we have heard in several news reports from reports of the national nursing organizations about the deaths of our nursing colleagues. And in relation to that, I would like to ask Ms. Annette Kennedy. The ICN has released the results of the latest survey conducted by the member of the national nursing organizations worldwide regarding the death tolls of nurses who died from COVID-19. So the results are very disturbing. I have read the report. And can you please tell us more about that report? And why do you think, why the global health leaders watching us right now should make it a priority for an immediate round the table? The floor is yours, Annette.
Thank you very much, and thank you for the invite. I hope to share the screen, but in the meantime, good morning, good afternoon, and good evening from a very sunny Ireland, believe it or not. And let's see if this works, because I have a love-hate relationship with. Can you see anything? No?
Yes, we can see your screen right now.
Can you see my slides?
Yes.
Okay. Let's see. Why isn't it?
And while waiting for Annette, I will check some questions in the Q&A, none so far. And also, in addition to what Elizabeth said, nurses really play a critical role in the achievement of universal health coverage and the sustainable development goals.
I'm here.
Yeah, sure.
Okay, thank you. Thank you for your patience. Just to say a few words about the International Council of Nurses, which I represent. It's the oldest, widest, and largest nursing organization in the world, over 120 years old. We represent more than 130 national nurses associations in the same amount of countries worldwide, greater than 27 million nurses. We have been probably the first NGO to be in official relations with the World Health Organization since 1948. And we have been working very closely with the World Health Organization across all areas of healthcare, and particularly now in relation to COVID-19. We have had a two-way communication with our associations since the very start of the pandemic. And since we heard from our association in China, we have been working across all countries, sharing information, collaborating, and that's the way that it works. You know, we share and we tell the things that worked and tell the things that didn't work. These are some of the things we sent out our first update on infections and what was happening in country in February. We sent out another call to action in March. The call to action was a 12-point plan, and it talked to our associations about what to seek from governments to support and protect the nurses. Because if you don't support and protect the nurses, you can't protect the patients. And it was all about ensuring that they had protection, ensuring that they had education, ensuring that their mental and physical health was protected, ensuring that they had occupational health priorities, that they had priority in testing, and many other things that we brought into also our recommendations following our survey. So we did a survey in August. We reported on it in September. And although we sent out the questionnaire to 50 countries, it was 50 of the most affected countries that we sent out the questionnaire to. But together with that, we looked up information from other sources, like government sources, like health organization sources, like academic sources, and any reliable information that we could get. And we put that together in relation to the healthcare infections as well as the nurse infections. because many countries don't collect detailed, comprehensive information. They collect a global look at the healthcare workforce as opposed to the different occupations and enough detail for us to protect the nurses. So we asked questions about infection and death among nurses. We asked about the supply of PPEs. We asked about infection prevention and control training, about violence, and about psychological support. And these are some of the findings that we had. More than 1,000 nurses have died from COVID-19, but that's in 44 countries. So that's more than likely to be well under a gross underestimation. We know that from Brazil alone, we have been told that in the health workforce, which could include health support workers as well as nurses, that 350 nurses and health nursing assistants have died by August. We know that in Mexico, 212 nurses have died. So we know that that's an underestimation of the number that have died. When we looked at the number of cases of healthcare workers that were infected, because it wasn't broken down by occupation, we found that 10% on average. That varied between countries dramatically, between 1% and 32%. But we'll say 10% is the average. I know that in fact, WHO have said 14%. And if you take the fact that 40 million people have been infected worldwide, we're talking about 4 million healthcare workers. Can we really afford to have one healthcare worker die, or one nurse die, or one nurse be infected because they're out of the system for the very least 10 to 2 weeks? But we've heard from some of our colleagues that they've been out for 14 and 16 weeks. So we are really depleting our health workforce who are already short. 70% of the courses reported violence and discrimination. And that's a lot down to misinformation, disinformation, and ignorance about healthcare workers. So some of them have had physical and psychological abuse. Some of them haven't been allowed to take accommodation because people are worried that they might bring infection there. They have also been not allowed on public transport at times. They have been, bleach has been thrown in a nurse's face. So there has been terrible, terrible violence perpetuated against our nurses. 24% of the countries do not offer psychological support to the nurses. This is really, really very worrying for all of us, because we know that the mental health of nurses have been affected by COVID-19. They're stressed, they're anxious, they've been deployed to other areas. We have young nurses coming in who don't get the support or the supervision that they need. And they're working with people who are dying. They're also seeing friends and family dying. They're worried about their own health. They're worried about bringing the COVID-19 back to their families. And they're the ones that are the only ones between the patient and their relatives, but their relatives can't visit. That is very, very stressful on anyone. And we know that that will have long-term effects, and we're extremely worried about that. 48% of countries recognize COVID as an occupational disease, but over 50% don't. And even the International Labour Organization said that getting COVID in workplace has to be recognized as an occupational disease. 45% don't have compensation for nurses. There has to be compensation. Some countries do very well and compensate the nurses, but not alone do they compensate the nurses, they give extra salary to nurses for actually going into an area which is high risk. 80% of the nurses have been offered testing, but they're offered testing when they have symptoms rather than offered testing on a regular basis or being monitored on a regular basis. And a number of countries have given education and training early on in the outbreak of COVID, but they haven't continued that, and things have changed a lot. We've got more information. We know that there's droplet infection. We know that there's aerosol transmission, but we need to continue to give education right throughout this whole outbreak and continuing. Otherwise, it's not appropriate for nurses not to have full information, so that, because they'll be the ones that will be teaching patients and relatives and the community. So this is very bad. The other thing about Amnesty International said that more than 7,000 healthcare workers have died by August. So what's our recommendations? Well, our recommendation is to implement standardized data collection of workers on their infections and death. This is so important, that not alone do we collect information, but we collect data on the occupation, their age, their sex, their ethnicity, their where they got the infection, and is there clusters there? Because if we don't protect the nurses and follow and all the healthcare workers, how can we protect the patients? Because we have to know the ways of transmission and how it's been transmitted and how it's been transmitted within the health area. So that is so important. We've been calling on governments since very, very early on to get standardized data. Some countries are doing it well, very few, but a lot of countries are not, and everybody's clubbed together. We have to recognize COVID-19 exposure as an occupational illness. This is very important. You cannot get an illness like this, which is can cause long-term effects or may cause death, without getting it being recognized and you getting compensation for it. Although the PPEs have improved in many, many areas, there are a lot of areas like community and like older person care places where it's not good enough and where it's not appropriate, and the sizing is wrong, or it's not of good quality. So we have to make sure that that's right too. Zero tolerance approach. We have been calling on governments for a zero tolerance approach to violent discrimination against nurses and healthcare workers. It's so important that we have governments calling this and putting out correct information. Nurses are not going to take COVID out of a hospital or anywhere else because they are so worried about taking the virus to their family or their friends or anybody else. They're not going to take any chances. Priority for nurses and healthcare workers for COVID-19 vaccines, that's a must, absolutely a must. They must have access to the vaccine when it comes out. How in God's name are we to have a health service if we don't have sufficient nurses and healthcare workers to provide it? Ensure healthcare workers have access and are prioritized for testing. Goes without saying that there should be regular testing and there should be regular monitoring of healthcare workers, particularly nurses who are closest to the patient. We know that in some hospitals it's done very well. We know that in other areas in community and nursing homes, it's not done well. Scale up measures to provide mental health. You know, the awful thing about this is that it's the National Nurses Association that has been provided a lot of support for nurses through webinars, through 24-hour telephone counselling, through providing mental health nurses to support online problems that nurses may wish to talk to them about. But this should be coming from government. It should not be coming from the NNAs. So all of those recommendations are not just essential, they should be, without doubt, everybody should have a priority in this that are working so closely with patients. And we urge all countries to commit to the WHO Health Workers Charter on Patient Safety, which was brought out on the World Patient Safety Day. And it's more or less very much in line with what we are saying, and we're asked all countries to, for goodness sake, sign up to it and implement the recommendations. And finally, what I would say is that, you know, there's been billions poured into COVID-19. Perhaps we should look at pouring billions into actually having resilient health systems, that when a pandemic occurs or when any kind of disaster occurs, that we're ready for it and that we're ready to keep our people healthy and safe. We worry about the economy, but if you don't have healthy people, you won't have a healthy economy. So let's invest, particularly, and I'll say this, invest in nurses, protect them and give them the money. Thank you.
Thank you so much, Annette. That sounds, at least for me, really disturbing, heartbreaking to hear that we have lost over 1,000 of nurses or even more because of the lack of resources of the personal protective equipment and protection of our colleagues. I hope that this wakens up politicians and stakeholders to better the working condition of our colleagues. Nurses are humans too, and they deserve utmost protection through legislations and better work pace. We will keep monitoring the condition globally. And I would agree also with when you mentioned about increasing the testing capacity. We test nurses all the time because they are really afraid when they go home, when they go back home, and they can pass the COVID-19 to their family members. And based, at least in my experience, I still have 2 colleagues in Denmark who contacted coronavirus in one big hospital, but still they have the coronavirus until now when it comes to testing. So let's keep monitoring the condition globally. And speaking of the deaths of thousands of nurses, one vulnerable group is the BAME group, also known as the Black, Asian, and minority ethnic groups in the society are also affected with this coronavirus. So Professor Dame Donna Keen-Eyre, United Kingdom is one of the countries with the highest deaths among BAME groups. So can you please tell us more about it? And what do you think are the occupational health measures and policies that the UK government has implemented to prevent the rising number of deaths among these minority groups? If you can please tell something about that one.
So very similar to the speakers that went before, nursing in the United Kingdom have stepped up to serve. But as you will know, we in the United Kingdom have suffered from approximately 50,000 shortage of nursing, and we're hugely reliant on overseas nurses, particularly since our announcement of Brexit. But actually, throughout our care services, I think we have about 110,000 shortage of nursing workforce. And these are for our care homes and many other sectors. So one of the things that we've been doing is making sure that we don't have this situation arise. Like Annette said, and Elizabeth, there's a huge importance for us to actually ensure that we train enough domestically trained nurses in order not to rely on our overseas. And certainly since Brexit, we have noticed as the Royal College of Nursing that we have turned to Commonwealth countries previously, as we lost approximately about 80 to 90% of our European colleagues at the announcement of Brexit. And again, like you said, the staffing shortages, I personally also volunteered during Brexit in one of our Nightingale hospitals, which were hospitals particularly set up to look after those that were suffering or needed ventilating. So we have been, as the nursing community, at the centre of response to COVID. And because of the furore that we've seen, and the very fact that in order to ensure that we had enough nurses, the very first thing that the nursing community across the UK had to do was actually come together and actually make sure that our students, we could put them into services without actually properly finishing some of their training. We also called on people who had retired from the service, and this was up to 4 years. So we actually wrote to all of them through the Nurse and Midwifery Council and asked them to come back into the workplace in order to help us. That this was both for medical and nursing staff. And we also noticed that actually the voice of nursing on some of these major platforms that were discussing nursing was entirely absent. So actually we, as the Royal College of Nursing, had to write to the Secretary of State for Health to say, where is the nursing voice? As actually most of the largest profession in the UK providing care at this time was nurses. And we then began to see our CNOs participating in some of those discussions. So it actually just showed the status of nursing. Although they came out and they clapped for us, it actually then showed that although we had been trying to grow the nursing workforce at a slower rate, the demand was definitely outstripping supply. And the pandemic just further highlighted the fragility of our workforce. So as you can see, we talked about it being a safety critical profession, because we know that we did not have enough nurses with that university education. Hospitals, we know from the information that we've received since 2014 report that hospitals with 60% of the nurses were graduates were safer than those where only 30% of the nurses were graduates. And we particularly saw this in our sectors outside of hospitals, where actually when we looked at the care home sector, very few people knew how to cohort patients in order to stop the nosocomial spread of infections. And actually what we found ourselves having to do was send in nurses from our community to enable some safety practice to be carried out in those hospitals. So throughout the pandemic, what we also found was that we had an inadequate supply initially of personal protective equipment. And that was because, although we'd been told over and over again that we had enough requirements to meet the specifications, and as we were entering into Brexit, what we actually found when we went to have a look was that some of our personal protective equipment was 10 years out of date, and that all over the country we had huge problems. The situation was totally unacceptable, and I found myself absolutely making this one of the singular important parts of campaigning for our members and for all nurses. If I give you an example, what we suspect was happening was people were trying to protect the inadequate supplies of PPE. And so we only at one point were giving personal protective equipment if you were working in some of our intensive care units. So actually what we were doing is we were sending people to A&E and the front line without any protection. And it wasn't until we got into a huge row as the Nursing Association and medical associations with our public health that we actually started to get this changed. And it took us, I think, until, if you think that lockdown happened in March, we didn't actually get this effective until the end of April, early May, by the time in which we secured personal protective equipment for all nurses that were delivering frontline care. Even in wards that were COVID, our public health seemed to be hiding behind World Health Organization guidance that was saying that you only needed personal protective equipment in aerosol generated procedures. We at this time argued about aerosol generated actions, which was a cough. And actually, I myself had a row with Public Health England, because actually what we did know was that some of our nurses and doctors were being infected, and yet they didn't have even an apron or gloves. So we then, in March, wrote to the Prime Minister and personally asked him to intervene in this situation. We also wrote an open letter to the Chief Executive of the Health and Safety Executive, and we called on their intervention to ensure that there was adequate availability of testing and that employers were complying with Regulation 4 of the PPE at Work regulations in 1992 that stipulated that adequate and suitable PPE should be provided to employers. And what we say today is it's essential that lessons are learned because of the shortage of PPE that nursing staff faced during the first wave of the pandemic. And it was unacceptable that only about 28%, and we surveyed regularly throughout this pandemic, of our members felt confident that they were being protected from COVID-19 in the workplace during the first wave. So we've called on the UK government to ensure that supplies of PPE are stockpiled and they're provided to all. The other issue for us was sickness. And one of the things that we expected was that all employers would support staff who were suffering from long COVID by continuing to pay staff COVID sick pay. We absolutely had to go to war to enable that all staff, and actually not just in the NHS, not just in independent sector, but also in the NHS, because we had a real differential between staff that were working in hospitals, those that had gone into private companies in the community where they were being refused statutory sick pay, including for those that were shielding. And so we absolutely went into battle, and we still continue to expect employers to support staff by providing them with long-term sick pay and leave arrangements. And we also expected them to make sure that any arrangements reassured staff that they would be supported even during secondary surges of COVID-19 over the winter period. Just in terms of the BAME issues, it became painfully obvious to us almost straight away that our first 10 doctors and I think it was first 8 to 10 nurses that died were particularly from the BAME community. We knew, not just from England, but also the impact it was having in the United States, that it was having a disproportionate impact on people from BAME communities. When we surveyed our members in April and May, we found worrying trends around the access that the BAME staff felt they had to PPE. Now, you wouldn't think in a hospital you could differentiate between who you were giving. But what we found was that many of our staff that were doing bank and agency had been relocated to frontline delivery of care in COVID wards. And actually we found some hospitals that were refusing to provide bank and agency staff with PPE. We quickly got that corrected. Can you imagine going to work and having to provide your own PPE? Our member survey revealed that for nursing staff working in high-risk environments, only 43% of BAME respondents said that they had enough eye and face protection equipment, compared with 66% of our British respondents, and 70% of our BAME respondents thought that they had been pressured to care for a patient without adequate protection. And that was almost double what was found in terms of our British respondents. So our respondents felt that they did not feel comfortable speaking out about their concerns. And the most common reason given to us, that was 68%, was they did not feel any action would be taken. And a third were fearful of retribution if they did speak out. So we actually made sure that as part of our response for any reopening of services, we called for full risk assessments to be carried out and for identified risks to be acted upon. So we wanted, for all nurses really, but full and proper risk assessments to control the risk of exposure to COVID-19, and that any identified underlying risks were actually acted upon. We were very clear that it was the employer's responsibility to ensure that staff are protected, which included actual timely access to testing. Now, I don't need to tell you here, but some of the fiascos that we had in terms of accessing testing, and it still continues in the UK, although we know that it has much improved from the early days. We actually asked for risk assessments to be reviewed regularly following any incident or change in circumstances, and that actually no staff was to be pressured into returning to work when their risk assessment said otherwise, because we noticed, if you actually think about the UK and think about who was on the front line providing a lot of the services, it is many of the BAME communities. So, and we actually called for a review and supported a review by Professor Kevin Fenton to actually look at the outcomes to BAME staff. One of the things that the review showed us was actually, although we knew that there was a disproportionate impact, the reasons were wide and varied, and whether it was because many people across the BAME community worked in frontline services delivering frontline care as bus drivers, as that was one of the reasons. Social workers may be one of the reasons why they were most infected. We still have to look at the outcomes for that, because we don't have enough evidence to give us the real reasons as to this, but it further supported working with those communities to deliver enhanced protection. And the other bit for us was really tackling the toll that COVID-19 has taken on the health of nursing staff and students who work through this stressful time and continue to work through this stressful time, witnessing traumatizing situations. We also know that as everybody has pointed to, that not only were we working at a time when we were stressed and worried about our own mental and physical well-being, but also the well-being of our colleagues. It never fails to leave me as an experienced nurse that the first time I stepped onto a Nightingale ward, and saw 40 patients being ventilated in rows one after the other, it absolutely does take a toll on you. And when 39 of those 40 are from the BAME community, now bear in mind I'm in London in the East End community, it also drives home to you the disproportionate impact that we've seen in some areas. So it's therefore essential for us that employers take urgent action to support the mental and health of nursing staff, but also the adequate protection of them through risk assessments. The other area that we've made some progress, and I know that people have talked about it being an occupational hazard in terms of pay, but actually all of our nurses have told us through a recent survey that they feel undervalued, and a third told us that they were considering leaving the profession. Nurses in England today earn significantly less now in real terms, if we took inflation into account, than in 2010, despite the government's protestation that they've given us a pay rise. The most experienced and long-serving nursing staff, who make up nearly half of the profession, saw the value of their salaries fall in real terms over the decade. So we can safely say that funding our health and care system is a must. We are very, very clear with this government that it's a political choice, and there is no point in clapping for us week after week on a Thursday when actually they don't personally value it. And that's why we launched a Fair Pay for Nursing campaign, which secures a consolidated 12.5% pay claim for all nursing staff. We'll see how far we get with that, but it's absolutely a must that actually people recognise that this is a critical safety profession, and that actually nothing else will do than paying us adequate. And that's how we intend to attract and keep people in the profession. So I just wanted to end there. I could go on to talk about international recruitment, but actually many of our UK's 12% of our nurses are internationally educated, are 4% qualified in the EEA. So I think there's a huge amount of work that we've yet to do on the immigration system post-Brexit, and we are still and remain concerned about the salary thresholds that they're asking for, particularly where we talk about social care staff. However, what I will say is that it is very clear to us that nurses throughout COVID-19 stood up, they left their families, they became an essential part of the workforce, and they did us proud. They did us proud wherever country you look at, whether I was talking to ICN or Spain or China, our nurses did us proud. So we are concerned about some of the issues, but actually it is important that we continue to ride on this wave of popularism that we have for nursing profession, to put some of the things that have gone so wrong for our professions right. And I continue to want to work with global nurses to do so. Thank you.
Thank you so much. I'm actually speechless hearing those data and facts you mentioned to me. 70% of nurses were not given adequate personal protective equipment when they were employed to COVID units, and that's very, very disturbing. And I do agree as well with you that educating nurses locally or domestically would be the sustainable solution, whereas not recruiting internationally educated nurses, although we can't prevent that from happening as well. And your work is truly appreciated when it comes to campaigning for the rise of the nurses' salary. Keep doing that. We truly appreciate that. And we take urgent actions on the mental health and well-being of our nursing colleagues. And I can remember my first coronavirus patient when during the peak season of COVID-19 in Finland. I was truly afraid. Okay, coronavirus. I haven't encountered that patient, but let's go. Wearing the right personal protective equipment and helping decrease the cases in Finland was my goal, and that was a very good experience for me. And thank you so much, Donna, for sharing your experience and very important data from the United Kingdom. And in relation to that, Sir Jim Campbell, after hearing all those data from our nursing leaders, what is the current situation now in the global perspective, including other healthcare workforce members? What can we do more? How do we translate these policies into actions? The floor is yours.
So thank you very much, Flora, and thank you to the World Health Summit and to the esteemed speakers who spoke before me. Good morning, good afternoon, good evening. Just listening to some of the presentation, it really does resonate with the data that we're looking around the world when we talk. I'm very, very glad that Professor Dame Donna Kinnear talked about health and social care in her area. We're seeing indeed many of the member states of the World Health Organization are jointly responsible for these mandates in one ministry, and they're having to contend with some of the increasing positive diagnosis and cases and the particular fatalities in the care sector at the same time as trying to drive improvements in health. In addition to the many points that they've made, I just wanted to bring together a couple of perspectives and then link back into this. We rightly see, as Elizabeth and Donna mentioned, a shortage in our existing health and care workforce worldwide. This is a phenomenon that has been brought to the attention of leaders and ministers for over a decade, that we need to invest in education and employment for health workers, and in particular the distinct occupations of nursing and midwives that we're celebrating in this international year. When each of those healthcare systems around the world has been tested with managing this pandemic, we're immediately seeing the redeployment of the workforce into surge capacity. The existing workforce and bringing others back into the workforce, or putting students into the healthcare system as an additional measure. And that means that there's inevitably an impact on the ongoing provision of all other healthcare services. The disruption that we've seen around the world is absolutely staggering. From high income, low income, middle income countries from every corner of the globe, the disruption to existing healthcare services is having a very, very significant impact on access to care, on the quality of care, and the provision of services, whether that's sexual and reproductive healthcare services, oncology services, pediatric services. There's still a major challenge. Then when we see what the stories we're hearing, when you have the impact on the health workers, on the nurses, through the lack of personal protective equipment, through the lack of training, through the impact and the risk assessments as we got better, through infections and being away from the workplace. So our workforce has been reducing and reducing even further. And that leaves colleagues having to manage continuously an overburden of work coming through. And now we're talking, as we look further forward, around the world, as just about everyone is using the expression of this second wave, but this continuing challenge and the increase again in number of cases, the number of hospitalizations, and the infection rates coming through. A further element of workload when many of these people are already spent 9 months of all the additional stress and challenge that they've had. And at the same stage, thinking forwards to a vaccine and the likelihood in 2021, but how do we then take on board the additional workload for a vaccine initiative, campaign, and program, call it what you will, that is going to be one of the largest ever in the world. And for a target group of the vulnerable, for the aged, for health and care workers themselves, for essential workers, that is really going to test our healthcare systems even further. And the reality is there are not enough nurses, there are not enough healthcare workers today in these healthcare systems around the world and social care systems to meet these same challenges without something really having to give. And so what the impact is we're rightly seeing there is a scramble around the world to recruit additional capacity, additional health workers accordingly. And we've seen this be translated into countries that have the economic capacity to recruit from abroad will continue to do so. Others are making regulatory conditions easier to license foreign-trained, foreign-born healthcare workers into the system. Other countries are actually putting a regulation to stop their health workers leaving the country and saying, no, you have to remain with us and be involved in our healthcare system so that we have our own capacity to do this. But there really is, I think, a bit of a revolution in regulation happening today in many, many countries around the world to actually fuel this capacity. So what are some of the challenges that we may see that we really have to address? I can only echo some of our earlier speakers that really this 9 months, well, the International Year of the Nurse and the Midwife that we had established was about, yes, celebrating the professions, recognizing and giving respect to the professions and the individuals around the world, the majority of whom around the world are women in the positions of leadership and clinical and research, but at the same time, really to take action. And that action was based on the evidence and the data that we were producing for the State of the World's Nursing Report in collaboration with Annette and her colleagues from the International Council of Nurses, from Frank Kakari, the president of the ICM, for the State of the World's Midwifery Report. What we've actually got on that evidence, as Elizabeth told us, was some clear directions of policy action that should be taken. What we've got additionally now is even more data evidence about the value of nurses, the value of midwives around the world today. And that's translated into even greater levels of respect for these professions. But we need to turn that respect into something which is critical. We need to turn that into the rights of the health occupations, the health workers, the social care workers. We need to have that turned into remuneration. We need to have, as Donna has rightly stated, fair pay has to be a decision of the political leadership, and to not just respect, but to reward and ensure their rights are upheld. We have to take action, as we rightly see, and we can't just, it's not acceptable that we have applause without action. And I think if this political imperative, this political choice, if you look at the reality of the economic recovery efforts and the investments of billions, as Annette was talking about, and the need to, we need to invest in our socioeconomic recovery, undoubtedly, but we need to steer some of that investment into the education and employment of the healthcare workers who provide our healthcare services. We need to steer that investment into leadership roles and development roles for the occupations. We need to make sure that we're putting on a commitment to long-term sustainable financing for both the increase in the number of education opportunities and then an immediate connection with the graduates into long-term employment and development opportunities. We have to address the overall shortage. We have to address the terms and conditions of careers and pay in the workforce. And so we've had this opportunity at the International Year of the Nurse and the Midwife. We've got the best evidence available, but we really now need to shift into this next year about seeing political leadership, senior health and care leadership taking positive action to address the elements that we're seeing through. Just a couple of points from just on the issues that were being addressed around mental health and trauma and health worker infections. We did a WHO publish, we've followed with real concern, since February and March, the impact on healthcare workers and infections and the fatalities and mortality around the world. We've seen the data that is available, and it's rightly agree with Annette, we need to improve and standardize the measurement and reporting around healthcare work infections. But with the data that we do have, there is some good news starting to come through. We looked, and yes, the figure overall cases, when we looked at data up into the first week of October from around the world, still a global number of about 14% of cases in healthcare workers. But the data that we're seeing in the period June, July, August is actually indicating that we're getting better. The risk assessments that Donna talked about, the health worker training, the IPC, the PPE availability was making a significant impact. And for those countries that were reporting data monthly, we're seeing the infection rate now amongst health workers being generally equivalent to the relation to the health workers in the population. So it's coming down to about 4%, which is indicating that we're getting much, much better at managing risk in health and care facilities and protecting our health workers. Nonetheless, even if this average is down to 4% today, it's still not acceptable. We still need to try and improve it even further. But there is some good news coming through that. And finally, just to the speakers and the audience, people are aware of this need to take action. We had the executive board special session of member states just a few weeks ago here in Geneva, virtual like today. And very notable that the recognition that in this 9 months in the global pandemic and reacting to COVID-19, health workers and care workers, absolutely critical to our efforts, recognition for their service around the world. And a proposal from Turkey, from the Minister of Health in Turkey, to the board members of the World Health Organization, World Health Assembly, that we must recognize that in 2021, give designation to all health and care workers around the world and have that as part of the feature for 2021 by WHO. So there is political awareness, political understanding. We must convert that into the actions at national level, which will give us the rights and the remuneration and the reward alongside the applause and the recognition. Thank you very much, Paul.
Thank you so much, Jim. We are waiting for the vaccine to come out next year, hopefully. And when it comes to vaccine, we hope that everyone has an access to it without hardship, even though low and middle income countries, but I know high income countries have already pledged that if the vaccine comes out, it will be part and it will be given free to the citizens of their home countries. Thank you so much for that one. And it looks like it's sunny in United Kingdom. I think Donna and also Annette. It's, yeah, the sun is shining. And here in Finland, it's very cloudy and cold. We are in the northern part of the country and would like to go out after this and take some fresh air. Yes, Professor Khatri, you have been very, very active when it comes to implementing evidence-based practice in your career. With your decades of experience in talking to the policy and decision makers in Finland, can you share us some best practices in nursing science, which made policy implementation a success? I mean, what are those challenges you encountered when talking to the decision makers? I know you've had a very good career when it comes to that one. Can you please share us your experiences?
Thank you, Flora, and it's wonderful to be here and listen and discuss in this enlightening. You can see my slide. Is it okay?
Yes. Yes.
Oh yeah. So first of all, I would like to say I come from, let's see if I can move my slide. As Flora, you said, I have a picture of I have been working in the University of Eastern Finland as well as in our university hospital. I'm a nurse and a midwife, and then have my academic career in the field of health sciences mainly. And our campus is quite solid. So we have the university hospital where I have my position as a nurse director, and especially the issues concerning evidence-based practice is my concern, as well as advancing nurses' skills in development and using research. So that's where we come from. And when I was listening to your talk, so I'm just in a way like concluding or coming to the, I started with reflecting this hard question, what you posed, Flora, to me in a way that, of course, we are now celebrating this excellent year of nurses and midwives, this international year. And we couldn't forecast in the beginning of the year, or maybe somebody could already, that what kind of an issue this is actually. And the pandemic, how it has shown the role of nurses all around the world, what nurses do, what is their impact. And just to, of course, everybody knows this, but when we look at how trusted profession nursing is, it's extremely interesting. We have all kind of rankings about the professions, and this is what comes out. All the colleagues there, of course, this is self-evident to you. As for evidence-based practice, for me, I always start with Nightingale, and as we are celebrating the 200 years, this is very important for me. As for evidence-based practice, of course, we need statistics, and this statistician was the lady who already at that time proposed these issues to us. So that was the case. And when we come to the point that we discussed here already about the education of nurses, so we have now evidence from several research reports on what's the role of nursing in our patient outcomes. What is the influence? So for example, here I took one example of this European research on RN forecast that also in this policy paper is discussed, where the study was produced from the evidence from 14 European countries. The similar type of repetitions have been done in different parts of the world, in China, in US, and so on, and in collaboration with different countries. So we know that when the nurses have the impact of nursing education on patients' mortality, for example, that has been shown in these studies. And when coming now to our pandemic situation, so I just reviewed from our International Journal of Nursing Studies, there was a review about 30 research papers, how nurses, what their experiences were during the springtime COVID-19 situation, so that how it was actually felt, what their experiences were. And we have heard from our prestige colleagues, from Elizabeth, Annette, from Jim, from Donna, so good descriptions about these things. But actually this review really showed also and gave evidence that protection from the nurse's point of view, protection and safety are they are so highly important issues. Protection of patients themselves, the safety of the environment, all these issues. Then knowledge and communication, of course, how this information is given, and especially how the organizations are prepared for COVID. were prepared. So I'm just summing up that it is really dealing about adequate leadership, how these issues were managed, and how the leadership was organized. What was the staffing situation? Because we all know that already all around the world we have the shortage of staffing, and especially in this situation. And the third one was about how the policy was actually launched. So these were, I would say that when listening to your talks, quite similar things come from these research papers that were reviewed. So now I want to still show you a few things about our case, Finland. As you know, we have about 5.5 million inhabitants in our country. A very good proportion, or the density of nurses is very high in comparison to many other countries in the world, actually. So we have over 72,000 nurses working in our country. And thanks to our nursing association, like what Annette mentioned also, that there's been surveys. So they did a survey to our registered nurses about the situation what was their working situation with coronavirus, and over 2,000 nurses responded. And what the alarming reports were, I must say that this was really alarming and very familiar to you. But these nurses that answered to the questionnaires, about over half were thinking to leave the profession, because this was during the COVID-19 time. Of course, they asked also about the situation before that, and it was less than 10%. And then the other issue is the burnout, or the anxiety and stress. In this survey, around 40% of nurses reported to be exhausted, and other 40% somewhat exhausted during this pandemic time. So think about this. And one we heard already, it was Jonna who you mentioned about undervaluing nursing. So also these nurses wrote in their open-ended answers that they really felt undervalued also in a country like Finland. So think about it. And the big issue in discussion in our country has been really the lack of financial compensation and support from our government to our nurses. We have had in our budgetary, on policy level, we have had additional budgets, biggest ones maybe never before, that has been given to different topics, but that wasn't given to our nurses working in the front line. So that was really something that was coming out in this type of a survey. Of course, not everybody was answering, but at least we heard about this. And thanks to our nursing association, National Nursing Association, this information was launched all over in our media, and at least everybody and also our politicians should know about this. So this was something to really that I highly appreciated. But still, as nurses said in our country, we need more than lip service. Lip service is not enough. And of course, we had some buildings lightened up in our metropolitan area for nurses, but it's not enough if you don't get any compensation. So I was just considering what would Nightingale say about things today. So I would say that she would be worried about nurses leaving the profession because of nursing stress, anxiety, burnout. And now I'm just talking in general about this, because this discussion has been going on according to many research reports for some time. And I noticed somewhere an estimation that in 2030 we would need over 7 million nurses. So this is an issue with all the retirement plans that nurses have. And the issue is, of course, that is nurses' expertise really understood? Is it properly understood in our society still? Would Nightingale think that because medical field technology has gone so far, so our nurses have totally excellent expertise, and is it really valued? And the issue about participation in decision making is, of course, an issue. And we have all this artificial intelligence, robotics, data science, but we need this kind of work like what nurses do. So Flora was asking how to advance this issue, and when combining it to COVID situation and more in general. So we definitely should invest what we have heard today in nurses education, on professional development and leadership, as well as, for example, I would like to mention for Finland that we don't have highly organized this advanced practice nursing system at all. So this is something that we are, for example, in our university, jointly with our Nurses Association now, doing work with this issue with international colleagues. The other issue is, of course, creating the decent working conditions. We talked about pay staffing and how actually these technological advancements, what we have already, how they actually support nurses' work. Is it supportive? And then how someone of you mentioned about that, how we actually get statistics, how we monitor nurses' support needs in a proper way, so that this is, and how policymakers take this into account. And we, of course, need leaders and managers and nursing experts in governmental and policy level. I have been lucky to have educated nurses in our policy level, as well as in our governmental level, to work together. So it has been a tremendous support to work on a root level in a way, and have the discussions and have a clear code. And of course, we need to use the evidence what we have, as Nightingale did already 150 years ago. So thank you for listening to my talk. Thanks.
Thank you so much. As a novice lecturer at the University of Applied Sciences, I can see the reactions of the nursing students when they hear the life story of Florence Nightingale, especially being a statistician. And they're really truly amazed, especially also hearing about her environmental theory, which is still very applicable nowadays when it comes to handling infection prevention and control measures. And we need statistics, we need evidence when talking to politicians, we need numbers, concrete numbers and data, so that we can move policies forward. And I think we have answered the two most important questions of this panel discussion. So let's go straight to the question and answer portion. And we can, any one of you can answer these questions. So we have one question here from Ms. Joanne Bobusanquet. Thank you, esteemed colleagues, a very enlightening webinar. I'd like to address the need for reflective practice and at least the availability of touch points or some time out in order to address anxiety, stress, and burnout. Thank you. How do we address stress and burnout among nurses? Yes, Ms. Annette.
Sorry, I have to unmute myself. Yeah, that is certainly a worry for all of us around the world, because we're seeing so much stress and burnout even before COVID-19. And you see with all the pandemics and the epidemics and the natural disasters that are actually making things worse. But what I would say is, yes, we need time out for reflective practice. We need to see what has gone right and we need to see what has gone wrong during these times. We need some of the countries have given extra time to nurses during this time, extra holidays, extra time out. We have asked several times for employers to look at the amount of time that nurses are spending actually on duty, because a lot of the times they're spending longer than their shifts. They're not getting time to have their breaks. They're in this protective clothing that isn't easy to take on and put on and take off. And so it's easier to stay in it than take it off. And we've heard earlier on that they weren't taking drinks and they weren't going to eat because that just takes time. We've heard good ideas about how they're having IV infusions outside of ICUs so that they don't have to be going in and out and changing protective equipment all the time. So nurses are coming up with great ideas about how they can do things better. But certainly reflective practice is the way to go. We need to learn from this COVID. We need to learn how we can better support our nurses. We need to have counseling. We need to have, I suppose we can't have gatherings together, but we can have webinars in where nurses can discuss their issues, their problems, their stress, their anxiety, and how we can do better by them. We have to support them. There is no two ways about it. Without nurses, there is no health service. There's absolutely no health service. And it's the least we can do is invest in looking after their mental health. We should invest in everything, but we have to invest in looking after their mental health. And just to say one thing, I cannot credit that in this day and age, when we're seeing a shortage of nurses, when we're seeing that we're 6 million short, and that we are now seeing that nurses will probably leave the profession or they will migrate, that the way to keep them is to say that we will implement legislation. That's not going to keep nurses. You only keep them by looking after them. You'll only keep them by looking after the socioeconomic welfare and their salaries. That's the way you will keep them, but you certainly won't keep them by legislation. And it's unethical and it's not right.
Yeah, thank you, Annette. Very important point to address the anxiety and burnout among nurses. And Jim also answered the question about how can we encourage men to go into a nursing profession. I would say that we should make nursing genderless. That's one point, and we promote more the value of men in the nursing workforce. Or do you have any other point to add on that?
Flora, I mean, obviously, this is a question that keeps on arising, and we've got better data than ever before on the age and sex distribution in the nursing profession around the world. And whilst there is in the under 40 group, there are some a better balance, it's still an area that we need to invest further in. There are some success stories in some countries where they've taken an active development in the undergraduate profiling and making sure that there's opportunities in the education, making that linked to the profession as well. So we're starting to see things, but at the same stage, the other element from the data tells us that often, men are getting to the top quicker than the women, even though they're a smaller percentage. So there's we've got to get the balance right. It's make sure that they're coming through and sharing the roles and not just cherry picking.
Yeah. So they always equate men to emergency nursing and operating room nursing, but I have done home care nursing and in infection disease, unit diseases also. So let's make it genderless, I think. too. So yes, let's. I think. Are running out of time because of the good discussion and the data that you present in this afternoon's panel discussion. So I would like to give each one of you a chance to give or deliver a message to the global leaders watching us right now, and also to our colleagues, our nurses who are watching us, and any inspiring, encouraging messages of hopes to them? Anyone can start. Miss Elizabeth, yes.
Thank you for a really fantastic opportunity today and to hear all the different perspectives, all really to strengthen nursing. I think for me, first of all, to nurses in the clinical field, in the communities and in education and research, I have to say your leadership, your commitment, your compassion, your courage, and your expertise will provide the sustainable challenge, the sustainable change we want in our health systems. The realities and the challenges exposed by COVID-19 in the health systems, and our understanding of the interplay of politics and the policy in health systems and impact on the economy, have been setting the course for nurse leaders to advance policy dialogue processes in countries and to influence that change. We need to remind governments and employers that investment in nursing is not a cost. COVID-19 has shown us there is a high cost for inaction. So let us continue to work collaboratively and use the power of our collective voice to strengthen and advance our profession through quality education, research, and practices of excellence. The distress COVID-19 has caused in countries points to realities affecting them and impacting health systems around the world and on our nursing profession. It has highlighted the relationship between politics, economics, health policy, public health, and healthcare workers, and especially nurses. So to global health leaders, employers, and governments, I call on your support to ensure that the nursing workforces are strong enough to ensure that everyone, everywhere gets the healthcare they need. I thank you.
Thank you, Elizabeth. And we proceed to Annette.
Yeah, my first comment to the government is to sign up to the State of the World's Nursing Report. The recommendations there apply across the board. 191 countries signed up to it. They have to implement. The second thing I would say, I am encouraged by what's happening now. I'm encouraged by the fact that COVID-19 has shown the indispensable value of nurses. We have to build on that. I think that nurses have an opportunity to change the narrative from health in hospital and treatment to health promotion, disease prevention, which I think we're very good at. Primary care, public health, screening, all of that. We have seen in many countries, and I know it's been said here, the advanced practitioners. I have seen them do great work across the world. I've seen specialists do great work in screening, in diabetes, in cardiovascular, in asthma, in cancer care, and taking the patients from the beginning to the end, which they like. We are losing that now because of the disruption to the health service. We need to get back to that. We need to build on that kind of nursing, and we need to build on community nursing. We need to strengthen all of that area. And what I say to government, if you want a decent health service, if you want a health service that's resilient, for goodness sake, invest in nurses.
I second the motion to the things that you mentioned, Annette. Invest in nursing, not 5 years from now, but now. And let's go to Donna. Any message to global leaders and to our colleagues in the clinical field?
So to nurses, I'm going to start with nurses. I want to say thank you. You have stood up and you have served and you have shown the world the importance of our profession. To world leaders, I say, listen to the World Bank. It makes economic sense to invest in our health and care workforce because that also means progression and prosperity for our countries. There is no economy without life, and therefore we need to make sure that life is still held as important, and we need to make sure during second waves or any other waves that this is an important character for those that we're looking after. Thank you.
Thank you, Donna, for your strong message to the global leaders and to encouraging words to our nursing colleagues in the clinical field. And we proceed to Katri.
Okay, so my message to the governments is that just invest in modern nursing. Thank you.
Thank you. Short but concise. Yes, and Jim?
Thank you. I'd echo what's been said, but also I think when we come out of 2020, there will be consideration for the leadership, the political leadership, on what they did, and whether what they did was the best that possibly could be. The mistakes have been making, and mistakes are human in this global pandemic. But did they really make an effort to invest in our health and care services, to invest in the nurses that lead those services, to invest in the multidisciplinary teams? And the public, whilst they will be forgiving when it comes to voting, they will be looking at the leadership accordingly. So if you are a political leader today, you need to make sure that you're on the right side of history when it comes to investing in health and social care.
Yes, thank you, global leaders, our nursing leaders. Now we unfortunately come to a point to end this panel discussion. We have agreed with the World Health Summit organizers that we will take your questions and then we will find answers to those questions after this discussion. So I would like to thank all the panel members again who have done an excellent work in uplifting and empowering our nurse colleagues who are in the clinical field. We are urging all governments and relevant stakeholders to invest in nursing, create legislations and policies to better the working conditions of my colleagues, increase their benefits, compensations, ensure that personal protective equipment is enough. Occupational health measures must be reviewed and give nurses ample time to rest in between stressful work periods, protect them from harassment, discrimination, and violence in the society during this pandemic period. Never forget too, the youth sector or the younger generation of nurses who have also contributed so much in taking good care of COVID-19 patients. Others have done it voluntarily and without even compensations. So I salute all of you for doing that one. Like with the key points in the State of the World's Nursing Report, we would like to reiterate again to the government officials to strengthen nursing leadership in the respective home countries, appoint chief nursing officers and include them in the policy and decision-making process, invest in nursing education, increase the budget for nursing education, train more nursing students, add more technological infrastructures, especially most of the teachings now are done virtually. I'm doing that myself. Increase resources for lectures and clinical instructors and provide them comfortable skill labs for teaching. Lastly, once more, we nurses deserve pay rise, not only during pandemic times, but also in a sustainable manner. Now is the government officials' turn to translate the claps and standing ovation into policies. We thank you all for joining us in this very important panel discussion for us nurses. I thank you once more to our distinguished panel of members for your time and effort. This means so much for my colleagues who are working in the clinical field. I salute you all for every single work you have done for us nurses. Kiitos oikein paljon. Tak. Maraming salamat po sa inyong pagsubaybay. Thank you so much for tuning in, and may the force be with us all. Thank you so much, leaders. Keep safe.